So, Alok, do you want to announce the
Yeah.
last
So,
speaker?
next speaker is Dr. Pragnesh Bhatt. Hello, everyone from Varanasi. Good evening to everybody, especially my science seniors like Dr. Kamat, Professor Ramani, and everybody. I'll invite Dr. Pragnesh Bhatt. He's also known to us, and he's always there in all the conferences. Very important topic: intraoperative neuromonitoring for intradural extramedullary spinal tumor. Please, Dr. Pragnesh Bhatt.
Thank you, Alok, for generous introduction. I will start sharing my screen. Thank you very much. An excellent organization. I congratulate the team of Bhubaneswar and NSSA in general, and I'm grateful for the organizers to give me this opportunity to present my experience over the last 13 years while working in Aberdeen. This is slightly controversial, but not as controversial as the previous. But compared to the first three speakers, it is relatively simpler, and they have made my job little bit easier when they talked about intraoperative neurophysiology monitoring. However, I was surprised that Professor Sarath Chandra did not refer to neurophysiology monitoring in newer adjuncts to removal of the intramedullary tumors. Let me see what I can do. I am going to address the topic under the following agenda. And since the original discovery by Galvani, lots of scientists have worked on the intraoperative neurophysiology monitoring either for scoliosis, for AVM, for spinal tumor. There is no controversy in the current literature regarding intramedullary tumors. However, the consensus has not yet reached about the intradural extramedullary tumors. The neurophysiology has become essential part of modern surgery. It increases safety for the patients by providing surgeons with real-time assessment of neural structures at risk, and evidence-based guidelines for its use are lacking, and therefore the indications for its use and experience of surgeons world over are variable. We were fortunate enough that we were spoiled by an excellent neurophysiologist who I will refer to it later on. He's a friend of NSSA and has visited many times India and even homes of Professor Moda. So going back to the next slide, referring to this paper, there are various types of modalities. I don't have time to go through, but SSEP, transcranial MEP, D-wave has become the gold standard, spontaneous EMG and triggered EMG, and we will use some of those in our presentation. The summary of important IOM related questions to be included in the preoperative checklist are: what monitoring modalities are most appropriate for the case at hand, and what types of neurological deficits are most likely? What anesthesia protocol will optimize acquisition of neuromonitoring signals? Is total intravenous anesthesia indicated? Can paralytics be used? What alarm criteria will be used for each monitoring modality? What actions will be taken in the setting of a positive alarm? And are new techniques involved? How will they be implemented? So this sort of discussions we have routinely between surgeons, neurophysiology team, and the anesthesia team. And between 2008 and December 2018, we had operated 50 patients. Now I have got a series of almost 65 patients with all intradural but extramedullary spinal tumor operated by a single surgeon. In addition to the standard clinical radiological assessment, every patient was discussed with the team, with neurophysiology and anesthesia to decide feasibility for monitoring. And I must say that over a period of time in our unit, intraoperative neurophysiology monitoring has become established practice for intradural extramedullary tumors. As usual, there were more female than males, and the distribution of tumors was almost majority meningioma or neurofibromas. Of the 50 patients we have analyzed for the European Congress last year, majority were in the thoracic location. We didn't have any in the cervicothoracic junction. We had one in the foramen magnum, which I'm going to illustrate at a later point. And we had usual share of cervical, thoracolumbar, and lumbar. The outcome was arbitrarily divided into excellent outcome, which means complete excision of the tumor, recovery of the neurological deficit, and surgeon's ease. Good, meaning thereby complete excision of the tumor, but possible not reversal of the neurological deficit, and some challenging with the surgeon. fair meant that the tumor was not completely excised, the neurological deficit did not improve, and the surgeon had some challenges. And one case had a poor outcome where, surprisingly, and we have had lots of opinion nationally, we haven't yet figured out what happened during the operation, but a lumbar neurofibroma patient woke up with quadriparesis, and we are still debating why. The evidence is in favor, and there are various options to monitor, and I would only highlight this, that the multimodal monitoring, there is a high evidence from the literature that multimodal neuromonitoring is sensitive and specific for measuring intraoperative neurological injury. And the other thing which I would like to emphasize is that there is high evidence that unimodal MEPs outperform SSCPs and EMGs with respect to test sensitivity, but are similar with respect to specificity. So that is what I would say. This is a very useful paper from Michael Fellings and group, and I would recommend those who are interested to refer to that. The key points from this paper are: based on strong evidence that multimodality intraoperative neuromonitoring is sensitive and specific for detecting intraoperative neurologic injury during spine surgery, it is recommended that use of multimodality intraoperative neurophysiological monitoring may be considered in spine surgery where the spinal cord and nerve roots are deemed to be at risk. And that is what we have done. There is a need for development of evidence-based protocol to deal with intraoperative changes in this situation. Now I'm going to illustrate a couple of patients. This is a young gentleman from Highlands who had unrelated arthritic condition but presented with sensory symptoms below the clavicle region, and investigations had revealed, as you can see. I hope you are able to see my cursor. I am pointing to this lesion in the foramen magnum. As you can see on the right side, it was partially calcified. We went through the usual motion of differential diagnosis, including we considered vascular lesion and had angiography, non-invasive, but essentially it is a right-sided extramedullary intradural lesion. And we have attempted all the cranial nerve monitoring, MEPs, SCPs, and free-running EMGs. Here you can see the top channel shows irritation of the ninth nerve activity in palatal muscles recorded via steel needles, giving warning of impending damage to this nerve. So there was some advantage. And as you can see, we have monitored various options there. I'm going to show you the post-operative images. So this is a post-operative image with a limited approach and the tumor completely excised, contrast scan, axial and sagittal with no residual lesion. And here you can see this is a very busy slide, but on the left top corner, you are seeing the free running EMG. On the right, you are seeing the stimulated EMG. On the bottom left, you are seeing motor evoke responses. And on the bottom right, there are 4 groups from right and left arm and leg somatosensory evoke responses, suggesting that we were all throughout very careful. So that was one extreme. And on the other extreme, I have a patient with a lesion in the conus cauda region L2 with a preoperative imaging T2 weighted image and T1 contrast with a lesion that was not very well defined. This was operated by, you can see we also use a probe and given activation of left medial gastrocnemius at 1. So tibialis anterior at T2, and sorry, at 2, stimulus has reached and thus located relevant roots of tibialis anterior. So sometimes either the cord is at a risk or the nerve root is at risk, and as appropriately we tailor our technique to the required. This paper was also very useful because when I presented the original cohort of my patients, we had 17 patients at the SBNS that we hosted in Aberdeen in 2012. There was still not enough support for intraoperative monitoring for this intradural tumors, but in this particular paper, they have analyzed surgeons with experience having intraoperative monitoring less than 2 years or more than 5 years, and they also had a huge volume of cases where less than 500 or more than 1500. And what it has shown is that those who had more experience, for example, those who had a long IOM experience, they had a high influence on their decision-making process. And similarly here, they are saying that they had high influence with more than 5 years of experience, but that was not necessarily always counterproductive. So usually this sort of influence is beneficial to the surgeons. I am coming towards the end of my presentation. So how to apply this knowledge? So monitoring techniques are tailored to risk reduction strategy for long tracks. Therefore, MEPs and SSPs are used more motor routes, and for peripheral nerve free running and stimulated EMGs are used as appropriate. So this sort of discussions will take place the day before. The communication with neurophysiologists is very important, as during complex monitoring, the surgeon may be aware of a risk to a particular structure, but without an operative field video display, the neurophysiologist may be focusing on a less important pathway. So we have a continuous dialogue and large screen monitors in theaters where they can also watch as much as the anesthetist and the rest of the team. And the neurosurgeon needs to understand what the neurophysiologist can and cannot detect. Since no technique is perfect, and application in theater can give practical difficulties. This is where I am reminded of the serenity prayer, that what I can and what I cannot, and the wisdom to differentiate between the two. We always respect our team. These are the couple of neurophysiology technicians, but the person who I want to thank the most is Dr. Alan Foster, who was the father of this in our unit, who is now retired and enjoying life, but was a frequent visitor to India for NSSA, and also has been to guest at Prakash Boda's house. In conclusion, I must say that though this is a retrospective study, not formally controlled, surgery was performed by the same surgeon, and we concur with the literature, especially Professor Sala from Italy is in forefront about the neurophysiology monitoring. And I know Professor Chatterjee also referred to another surgeon. And I know in India, Professor Chatterjee and the group are leading intraoperative neurophysiology monitoring, which I respect. So the planning of relevant techniques for identification of structures and early warning of potential permanent damage gave clear benefits in difficult cases where potential problems could be anticipated. I thank you for your patient listening. I am available for questions. Thank you.
Thank you, Dr. Pragnesh. In fact, it was very important for us, and it is a very informative lecture. I tell Dr. Kamath Anand to coordinate with the question because he was there in all this thing.
So we have got another 5 minutes, and if anyone has any questions, please direct to the proper speaker. Please go ahead. Any questions?
Can I, Dr. Kamath?
Yes, please go ahead, Varnan.
Yeah, Dr. Pragnesh, good talk. Congrats. Okay,
Thank you.
2 questions to you. One question is, what is your experience when you're doing tumors which are involving the motor nerve root, number 1? And when you're working on tumors in the brachial plexus, so do you have, because that is one of the places where you would require the monitoring the most, basically, rather than sensory nerve roots. Because sensory nerve roots, sometimes you might, if you do not get a good plane, you might even, knock them off. That's
Thank
what.
you.
But if they are motor nerve roots, I think you got to have a mandatory intraoperative monitoring. And if they are brachial plexus tumors.
Thank you very much, Professor Varnan, for an excellent question. The second question is easy for me to answer. I have no experience of brachial plexus tumors. However, I have operated on peripheral nerve tumors with neurophysiology monitoring, and they are very useful. I have had the opportunity to do those while I was in New Zealand for a year. So I would strongly recommend that for peripheral nerve tumors also. Coming back to the motor tumors, I completely agree that sensory and most of the neurofibromas are easy because they are arising from posterior nerve root, and some of the rootlets you can sacrifice very easily. The challenge occurs when they are intrafascicular, and that's where the surgeon's wisdom, and I refer to the serenity prayer, that I have to decide between the things I can and the things I cannot. And God has granted me the wisdom to differentiate the two. Thank you.
Okay. And the second question is sometimes the monitoring can be a real pain. Okay. I'll tell you, there was a recurrent intramedullary hemangioblastoma, which was referred to us. And this was recurrent. It was not recurrent. It was not operated only in the first stage, and it was involving the lateral medulla. Okay, and Alok Oja is smiling. This patient came from neighboring hospital. I won't tell you. Okay, sent by our junior. Okay, and this patient we operated. We started. And as I was dissecting the tumor, the physiologist started shouting, MEPs have gone, MEPs have gone, MEPs have gone. And all mayhem broke loose. But I had not coagulated anything. Nothing was coagulated. The tumor was not out. The tumor was still there. And he was keeping on shouting, sir, MEPs are out, MEPs are out. But finally, we went ahead. I just went ahead and there was no stopping. I removed the tumor and the patient is fine. Post-op, all the MBPs came, okay, and everything is okay. So sometimes they can, hinder your work. You might end up leaving most of the tumor. Although now we say, okay, especially I think in the European countries, they're very, very sensitive about monitoring, neuro monitoring. So what's your take? I think I want Kamath also to respond since he's also in the NHS. What is your take? If the MEP stop, do you stop and say, okay, now let's close?
Dr. Pragnesh Bhatt, please answer him.
Thank you very much. So we rely on D waves more than MEPs. I have not is more sensitive and more interesting, and previous three speakers have given enough justice, so I would keep that away. But between the MEPs and D waves, we keep a very close watch on D waves, and if there is more than 50% reduction of MEPs, we temporarily abandon the procedure or work at a different level. And I have had my fair share of learning. For example, I was operating on a tumor which was largely left-sided with a cord pushed to the right, kept a patty to keep the things separate, and due to constant irrigation, the patty got heavier and heavier. And suddenly when the neurophysiologist said that, what are you doing? The right-sided responses have gone away. And I was working on the left side. But then we realized that it was the patty which was getting heavier due to constant irrigation. And that's when we had to remove. So sometimes learning through the experience. So I would say my comfort with the neurophysiology monitoring is much better now as compared to what it was 10 years ago when I was a beginner. I hope that answers, but I agree that intramedullary hemangioblastomas are the greatest challenge because they have to be taken out completely, and they could be a bigger challenge.
Kamath, Dr. Kamath.
Well, I agree with you. I think if the lesion is aggressive and leaving it behind is going to cause more problems, better to take it out irrespective of what you find. So I can say that we have finished in time, and I think we can conclude this session. Thank you, everyone.
Thank you.
Thank you.